But we'll start by talking about probably what is the most controversial part of the study, which is PD-L1 expression. And what was unique in this study was the stratification factor. So we have to take stratification factors seriously. And PD-L1 was looked at by TAP. The group of patients that were PD-L1 negative were about 10%, so smaller than perhaps some of the metastatic disease literature would have implied. And there was a lot of debate as to what happened because the confidence intervals, or the forest plots, I should say, stretched over the median for that subgroup. And, what does that mean? And I'm open to hearing comments from my colleagues here about how they interpret this information and how have they extrapolated that piece of data into their practice.
Yeah, I would say, I'm sure all of us would agree, upper GI cancer is tough to treat. This is the curative setting. For me, I acknowledge that the trial was never intended to look at efficacy based on PD-L1 status. As you mentioned, there were 10% who were PD-L1 negative. Looking at those forest plots, it's interesting that the hazard ratios, they're like the same, 0.790 for overall survival. But as you mentioned, the confidence interval is wide for PD-L1 negative, but I think it's the numbers, right? And from my perspective, I offer it irrespective of PD-L1, acknowledging that many of our patients, they don't see subsequent therapies.
Right. Okay. So I think the point you made, which is a good one there, is that I didn't get to the overall survival, but the overall survival was met of the study. That was the secondary endpoint, and that was met a few months later. The manuscript is actually in press right now for that, but it was met, which I kind of agree with you, changes the calculation a little bit in my mind. Tim, what do you think?
Yeah, so we have data in the metastatic setting that shows that you have to have PD-L1 expression to derive benefit from immunotherapy. So it did give me a little bit of pause seeing those confidence intervals cross 1, although seeing the point estimate of the hazard ratio be consistent with the overall hazard ratio for the study is very reassuring. To date, my practice is to go ahead and offer it irrespective of PD-L1 with the understanding that there may or may not be a benefit in this particular group.
Fair.
Yeah, I'd just like to say that I find PD-L1 to be a very unreliable biomarker in upper GI because you can have multiple biopsies with sort of different results. And if I just were to just bring about the esophageal adenocarcinoma where we give adjuvant immunotherapy to all patients with benefit, that I feel that the PD-L1 as a biomarker is not necessary, unless we randomize for that, is not something I can interpret as good or bad in this clinical trial. That's sort of my interpretation of PD-L1.